Welcome to this presentation on the nursing management of patients with hematological malignancies, including leukemias, lymphomas, and myeloma. Presented by Mr. Chan Z Man, an advanced practice nurse at Prince of Wales Hospital from Hong Kong, and supported by the International Society of Nurses in Cancer Care. Hematological malignancies, commonly known as blood cancers, are a significant group of cancers worldwide. They are typically categorized based on the site of origin, whether detected in the blood, lymph nodes, or bone. This includes leukemias, lymphomas, and myelomas. Leukemia is a type of cancer that affects the early blood-forming cells in the bone marrow. It is characterized by the rapid growth of abnormal blood cells, leading to the suppression of normal cells. Leukemia cells are usually immature white blood cells. The term leukemia comes from the Greek words for white, leukos, and blood, hema. Unlike other cancers, leukemia doesn't generally form a mass tumor that shows up in imaging tests, such as X-rays or CT scans. Leukemia is classified into 4 main types based on the type of white blood cells affected and the progression speed of the disease. These include acute lymphocytic leukemia, ALL, acute myelogenous leukemia, AML, chronic lymphocytic leukemia, CLL, chronic myelogenous, myeloid leukemia, CML, and chronic myelomonocytic leukemia, CMML. Acute types progress rapidly, while chronic types progress more slowly. Acute lymphocytic leukemia, ALL, is the most common type of leukemia in children, teens and young adults up to age 39. ALL can affect adults of any age. Acute myelogenous leukemia, AML, is the most common type of acute leukemia in adults. It's more common in older adults, those over 65. AML also occurs in children. Chronic lymphocytic leukemia, CLL, is the most common chronic leukemia in adults, most common in people over 65. Symptoms may not appear for several years with CLL. Chronic myelomonocytic leukemia, CMML, is more common in older adults, most common in people over 65, but can affect adults of any age. It rarely occurs in children. Symptoms may not appear for several years with CMML. Leukemia presents with various signs and symptoms, including petechiae or small red spots on the skin, fatigue and fever, swollen lymph nodes, anemia, night sweats, enlarged spleen, kidney and liver, pain in bones and joints, bleeding tendencies, and weight loss. Several factors increase the risk of developing leukemia, including exposure to radiation such as atomic bomb radiation and medical therapeutic radiation. Infections such as the human T-cell leukemia virus, chemical exposure to carcinogens like benzene that may present in some paints, solvents, pesticides, detergents and unleaded gasoline. previous chemotherapy for other cancers, a greater risk of secondary AML for the breast cancer patient who have been treated modern chemotherapy drug, a family history of leukemia or certain genetic conditions that predispose individuals to leukemia, racial differences in incidence rates. For example, ALL has the highest incidence in Hispanic white, with the lowest incidence in blacks, and smoking are significant risk factors for developing leukemia. Diagnosing leukemia involves a physical exam to look for any physical signs of leukemia. Doctors will ask about your symptoms and feel for swollen lymph nodes and an enlarged spleen or liver. They may also inspect your gums for bleeding and swelling. They may look for a skin rash associated with leukemia that may appear red, purple or brown. Complete blood count and peripheral smear to check for abnormal levels of blood cells including red or white blood cell or platelet. If you have leukemia, you'll likely have higher than normal counts of white blood cells, and flow cytometry, immunohistochemistry, cytogenetic tests to detect specific proteins on the surface of cells. Bone marrow aspiration and biopsy are also crucial for diagnosis and help to determine the percentage of abnormal cells in your bone marrow, confirming a leukemia diagnosis. Further diagnostic tests include immunohistochemistry to identify antibody-marked proteins, flow cytometry to determine cell types, cytogenetics to examine chromosomes, and PCR to find changes in genes. These tests help in understanding the specific type of leukemia. Bone marrow aspiration and biopsy is to use a thin needle to remove a small amount of liquid bone marrow, usually from the back of the hip bone called pelvis. A bone marrow biopsy is often done at the same time. It removes a small piece of bone tissue and the enclosed marrow. This procedure helps in detecting leukemia cells and examining the bone tissue and marrow. It is essential for diagnosing and understanding the spread of leukemia cells that have spread into the cerebrospinal fluid surrounding the brain and spinal cord. Usually patient may feel a little pain and need to have a complete bed rest for several hours to observe wound condition. Lymphoma is a cancer of the lymphatic system. The lymphatic system is part of the body's germ-fighting and disease-fighting immune system. Lymphoma begins when healthy cells in the lymphatic system change and grow out of control. The lymphatic system includes lymph nodes. They are found throughout the body. Most lymph nodes are in the abdomen, groin, pelvis, chest, underarms and neck. The lymphatic system also includes the spleen, thymus, tonsils and bone marrow. Lymphoma can affect all these areas and other organs in the body. This can impact both B cells and T cells, leading to various health issues. There are two main types of lymphoma: non-Hodgkin lymphoma and Hodgkin lymphoma. Non-Hodgkin lymphoma is characterized by the presence of Reed-Sternberg cells and accounts for about 90% of lymphoma cases. Hodgkin lymphoma has a distinct appearance in biopsies. there is no way to prevent lymphoma. Lymphoma presents with warning signs such as fever, swelling of the face and neck, lumps in the neck, armpits, or groin. Excessive sweating at night, unexpected weight loss, loss of appetite, breathlessness, itchiness and a feeling of weakness. Several risk factors increase the likelihood of developing lymphoma, including occupational exposures, people working with textiles, heavy automotive equipment, welding, farming, landscaping, hair and cosmetics may be at an increased risk. Infections with viruses or bacteria such as HIV, Epstein-Barr virus, hepatitis C virus or Helicobacter pylori are at more risk. Ethnicity, NHL is more common in those with Caucasian ethnic background, people who are taking immunosuppressants that are more susceptible to NHL. Older age, NHL incidence is strongly related to age. Risk increases in older individuals and gender. For example, non-Hodgkin lymphoma is more common in men than women. Diagnosing lymphoma involves a medical history and physical exam, blood chemistry studies, lymph node biopsy, bone marrow biopsy, and imaging tests such as MRI, CORT, or PET scans. These tests help in identifying the type and extent of lymphoma. Multiple myeloma is a cancer arising from plasma cells, a type of white blood cell made in the bone marrow. Healthy plasma cells help fight infections by making proteins called antibodies. Antibodies find and attack germs. In multiple myeloma, cancerous plasma cells build up in bone marrow. These cells become abnormal, multiply uncontrollably, and release only one type of antibody, known as monoclonal protein, which has no useful function. Multiple myeloma presents with various signs and symptoms, including confusion, recurrent infections, kidney problems, bone and back pain, bone fractures, fatigue, unexplained weight loss, spinal cord compression, nausea, and excessive thirst. These symptoms are due to high calcium levels and kidney damage. Patients with multiple myeloma may experience confusion due to high calcium levels in the blood and/or kidney failure. Fractures. Myeloma cells trigger the destruction of surrounding bone. The weakened area of bone is more likely to break. Fatigue and/or shortness of breath. Myeloma can cause anemia. Numbness or weakness. Myeloma is sometimes associated with nerve compressions. Weight loss and/or loss of appetite may be due to high calcium levels in the blood and/or kidney failure. Frequent infections. Because myeloma cells crowd out normal white blood cells, which fight infection, there is a risk of infection. And excessive thirst. These symptoms are often related to high calcium levels and kidney damage. Multiple myeloma symptoms vary from person to person. Often, in the early stages of disease, there are no obvious symptoms. When they are present, Symptoms may be vague or similar to those of other conditions. Interestingly, about 10–20% of patients may not show any symptoms initially. Risk factors for developing myeloma include genetic abnormalities, bone marrow abnormalities, age over 60 years, exposure to certain chemicals or radiation, race, African American, and being overweight. These factors contribute to the likelihood of developing the disease. Diagnosing myeloma involves a physical examination to reveal bone tenderness, soft lumps, neurological signs related to spinal cord compression, as well as enlarged liver, spleen and tongue. Blood tests, looking for M protein and beta-2 macroglobulin, also kidney function, CBP, calcium levels and uric acid levels, bone marrow biopsy, urine tests which may show M proteins aka Bence-Jones proteins, imaging tests such as X-ray, MRI, CORT, or PET scans. These tests help in identifying the presence and extent of myeloma. Surgery and chemotherapy are key treatments for hematological malignancies. Surgery is often used for supportive care, such as splenectomy, while chemotherapy is to use of certain kinds of drugs that destroy or control the growth of cancer cells. Based on the treatment goals, phases of treatment in some subtype may include an induction phase, primary and initial treatment, a consolidation phase, enhancing or adding to the initial treatment, and a maintenance phases, to maintain the remission achieved in previous phases. The treatment goals and phases vary depending on the subtype of cancer. Targeted therapy, immunotherapy, and radiation therapy are additional treatments for hematological malignancies. Targeted therapy attacks specific chemicals in cancer cells, immunotherapy boosts the immune system, and radiation therapy uses high-powered beams to destroy cancer cells. There is no cure for multiple myeloma. However, there are many treatment options, with new ones emerging every year, to effectively manage the disease. You and your doctor will determine a treatment plan designed for you and the specifics of your multiple myeloma diagnosis. Knowing what options are available can help you determine with your care team which treatment is right for you. Bone marrow and stem cell transplantation are crucial for treating certain blood cancers. This process involves replacing unhealthy stem cells with healthy ones, either from the patient or a donor. SCT is a major treatment modality that holds curative potential for hematologic disorders. It can be used to treat conditions affecting the blood cells, such as leukemia, lymphoma and multiple myeloma. Autologous stem cell transplants. The stem cells come from patient blood. Allogeneic stem cell transplants. The stem cells come from blood or bone marrow of someone else. Undergoing an autologous stem cell transplant involves taking medications to increase the number of stem cells in your blood. You'll receive medications that cause your stem cells to increase in number and to move out of your bone marrow and into your blood, where they can be easily collected. filtering stem cells from your blood. For stem cell collection, a needle is inserted into a vein in your arm or through a central venous catheter to draw out your blood. A machine filters out the stem cells and the rest of your blood is returned to your body. A preservative is added to your stem cells and then they're frozen and stored for later use. Undergoing high doses of cancer treatment, conditioning. During the conditioning process, you'll receive high doses of chemotherapy or radiation therapy, or sometimes both treatments, to kill your cancer cells. The treatments you undergo depend on your disease and your particular situation. The cancer treatments used during the conditioning process carry a risk of side effects. Talk with your doctor about what you can expect from your treatment. Receiving an infusion of stem cells. Your stem cells will be infused into your bloodstream, where they will travel to your bone marrow and begin creating new blood cells. After your autologous stem cell transplant, you'll remain under close medical care. You'll meet with your care team frequently to watch for side effects and to monitor your body's response to the transplant. An allogeneic stem cell transplant is a procedure in which a patient receives blood-forming stem cells from a donor. The rationale for allogeneic stem cell transplantation is twofold. A chemotherapy or radiation-based treatment before transplantation, called conditioning, enables the elimination of the harmful leukemic cells. An undesirable effect, however, is the destruction of the patient's immune and blood-building systems. Therefore, the first goal of allogeneic stem cell transplantation is to replace the patient's blood and immune system with a healthy one from a donor. The second goal and major advantage of this approach is that newly generated immune cells attack residual leukemic cells, called the graft versus leukemia (GVL) effect. This makes the disease less likely to return. In an allogeneic stem cell transplant, stem cells are donated by a healthy individual whose tissue and blood cell type are compatible to the patient. Frequently, the donor is a sibling with an identical tissue type. Other immediate family members can also serve as stem cell donors. Following a successful stem cell transplant, the bone marrow is repopulated with blood stem cells from the healthy donor, which will rebuild the patient's blood and immune systems. This step is critical for the effective treatment of AML. CAR T-cell therapy is a type of immunotherapy. CAR stands for chimeric antigen receptor. CAR T-cell therapy is a very complex and specialist treatment. With this treatment, a specialist nurse collects your T-cells. These are then sent to the laboratory where a change is made to the T-cell to become CAR T-cells. After a few weeks, you have a drip containing these cells back into your bloodstream. The CAR T-cells then recognize and attack the cancer cells. It is a possible treatment for children and adults with relapsed or refractory B-cell acute lymphoblastic leukemia, ALL. It is also a possible treatment for adults with relapsed or refractory diffuse large B-cell lymphoma, DLBCL, primary mediastinal large B-cell lymphoma, PMBCL, mantle cell lymphoma, MCL, and, most recently, multiple myeloma. People with other types of cancer might have it as part of a clinical trial. How does CAR T-cell work? T-cells are collected from the blood. This process is called apheresis. In the laboratory, scientists change the T-cells to become CAR T-cells. They do this by adding a gene to the T-cell that causes the cell to make proteins on their surface called chimeric antigen receptors, CARs. The CARs can recognize and target a specific protein on the surface of the cancer cells. These changed T-cells grow and multiply in the laboratory. Once there are enough CAR T-cells, you have a drip containing these cells back into your bloodstream. The aim is for the CAR T-cells to then recognize and attack the cancer cells. The changes they make in the laboratory mean that they can stay in your body for long periods of time, recognizing and attacking the specific cancer cells. Patients with hematological malignancies require specialized nursing care due to impaired bone marrow function. Treatment options vary, and each has different implications for patient care, including short-term and long-term. This section will discuss the nursing care. Infection control and management are critical for patients with hematological malignancies due to their compromised immune systems. Patients with hematological malignancies are at risk for infection due to the disease's impact on the bone marrow and immune system. Chemotherapy and other treatments can further suppress the immune system. Closely monitor the temperature. Observe for fever-associated signs and symptoms. Febrile neutropenia is the most common life-threatening complication of cancer therapy. Its treatment is an oncological emergency. Prompt empirical antibiotic therapy has dramatically improved outcomes and decreased mortality from febrile neutropenia. Place in private room or isolated in positive pressure room when patient's immune system is suppressed. Limit visitors as indicated. Prohibit live plants or flowers. Restrict fresh fruits and make sure they are properly washed or peeled. Coordinated patient care, so that patient doesn't come in contact with staff who also care for patients with infections or infectious diseases. Encourage increased intake of foods high in protein and fluids with adequate fiber. Provide low bacterial diet as indicated. Maintain good personal hygiene, such as oral, hand and perianal hygiene. Avoid using indwelling urinary catheters and giving IM injections due to low platelet count. Educate the patient or relatives of the central line care, PICC or Hickman line, according to your facility's policy. Limit invasive procedure as possible. Low bacterial diet is also called neutropenic diet. It is an eating plan for people with weakened immune systems. It involves choosing foods and preparing them in a way that lowers the risk of foodborne illness. The basic principles of this diet involve practicing proper food safety and avoiding foods that are more likely to expose patient to microbes and bacteria. People who've had a stem cell transplant typically need to avoid food prepared in restaurant or other establishments for 100 days. Food guidelines as follows. Avoid raw and undercooked meat, shellfish, eggs and unpasteurized products. Avoid leftover older than 48 hours. Proper hand washing is the first important step in food safety. Thoroughly rinse fresh fruit and vegetables under warm running water. Scrub or brush produce to remove excess dirt. Use clean dishes to serve cooked food. Avoid keeping food on the counter longer than necessary. Refrigerate or freeze food immediately after purchase. Do not defrost food on the counter. Refrigerate or freeze leftover food within 2 hours of eating. Check that the refrigerator is set at 40 degrees or below. Maintaining appropriate food intake is crucial for patients with hematological malignancies. Patients with hematological malignancies are at risk for deficient food intake due to several factors, for example, the side effect from chemotherapy or resulting from fever. Patients may suffer of vomiting, diarrhea, poor appetite, dehydration and fatigue. Monitor intake and output. Calculate insensible losses and fluid balance. Note decreased urine output in presence of adequate intake. Measure specific gravity and urine pH. Tumor lysis syndrome occurs when destroyed cancer cells. Potassium, phosphorus, and uric acid is released. Elevated phosphate and uric acid levels cause crystal formation in the renal tubules and leading to renal failure. Weigh daily, monitor blood pressure and heart rate. Note the presence of nausea and vomiting. Encourage fluids of up to 3 to 4 liters per day when oral intake is resumed. Encourage foods with high protein, high calorie and high fiber. Eat small and frequent meals. For example, have 6 to 8 meals a day instead of 3 main meals. Eat patients' favorite foods at any time of the day. Make food that smells and tastes good. Eat easy digested food such as congee and noodle. Administer intravenous fluid, total parenteral nutrition, TPN, or medication as indicated. Patient with hematological malignancies may experience acute pain due to physical agents such as bone or joint involvement, chemical agent form chemotherapy or radiation therapy, and psychological manifestations such as anxiety or depression. Investigate reports of pain. Note changes in degree, use a pain scale, and cite. Monitor vital signs, and note nonverbal cues, for example, muscle tension, and restlessness. Monitor uric acid level as appropriate. Destruction of cancer cells during chemotherapy can elevate uric acid, and causing swollen painful joints in some patients. Massive infiltration of WBCs into joints can also result in intense pain. Provide a quiet environment and reduce stressful stimuli. Limit or reduce noise, lighting, and constant interruptions. Encourage the use of diversional and relaxation activities such as listening to music, deep breathing exercises, watching TV or movies or talking with friends and family. Evaluate and support the patient's coping mechanism. Administer medications as indicated. Enhancing tolerance to activity is important for patients with hematological malignancies. They may experience activity intolerance due to generalized weakness from the disease process, therapeutic restrictions related to treatment protocols, anemia resulting from bone marrow suppression, and reduced energy levels. Supporting patients in gradually increasing their tolerance to activity can help improve their physical fitness and enhance their quality of life. Evaluate reports of fatigue, noting inability to participate in activities or ADLs. Monitor and record vital signs and oxygen saturation levels. Assess client for signs of dyspnea or chest pain. Encourage patient to keep a diary routines and energy levels. Helps patient prioritize activities and arrange them around fatigue pattern. Provide quiet environment and uninterrupted rest periods. Encourage rest periods before meals. Implement energy-saving techniques, sitting, rather than standing, pacing activities, using a shower chair. Assist with ambulation and other activities as indicated. Encourage oral intake. Encourage moderate exercises as indicated such as guided stretching exercise, short walk and yoga. These activities can help to enhance cardiovascular and muscular endurance, promote balance and flexibility, and improve overall functional capacity. Health teaching and patient education empower patients to manage their treatment and adopt healthy lifestyle practices. This includes understanding their condition, learning about treatment options. Provide psychological support by establishing a trusting relationship to promote communication. Involve family members or support persons in the education process, teaching the skill and knowledges about the potential complications. Care on anemia, for example, eating high iron and vitamin B6 foods. Care on bleeding tendency, for example, avoid injury and no suppository. Assess skill about infections, neurologic status, skin integrity and nutritional status. Knowledge about taking medication, for example, taking antiemetic should be 1 hour before meal, using around-the-clock rather than PRN analgesia when pain is severe. Let's have a case study. A 45-year-old man presented on and off low-grade fever, fatigue and swollen lymph nodes on neck. Blood test, neck biopsy and bone marrow biopsy was performed. He was diagnosed of NKT cell lymphoma. He is receiving the 2 cycles of chemotherapy, SMILE protocol, dexamethasone, methotrexate, ifosfamide, asparaginase A and etoposide. He is recommended to have low bacterial diet. Why the patient needs to have low bacterial diet? What is low bacterial diet? Some cancer treatments can weaken the immune system, making you more susceptible to infections. This means that cancer patients can often be in an immunocompromised, or neutropenic, state. This case study of a post-chemotherapy patient highlights the importance of a low bacterial diet. This diet is recommended to reduce the risk of infections due to his compromised immune system. References provide the sources of information used in this presentation, ensuring the accuracy and credibility of the content shared. Thank you for your attention. If you have any questions, please feel free to